Okay, hi again, once again. So I'm here again with yet another session for the talks. I hope you guys are getting benefited out of them. So yesterday we have had a session with Dr. Pradnia on PPH, recent talk article. And today we are going to cover recurrent pregnancy loss talk article, as well as because we have got a new, the guideline, Green Top guideline, after that talk article. So I will try to conclude this whole topic, recurrent miscarriage. So I hope this is going to be the kind of complete session in terms of recurrent miscarriages or recurrent pregnancy loss. All right, so let's get started. So you guys know me, I'm Dr. Zaib Qureshi. I'm a senior mentor of MRCOG, MRCPI, the APCOG at MedExam Expert. And yes, today I'll be talking about the TOG article. Okay. So this is going to be the current management of recurrent pregnancy loss. This is TOG 2022, last year TOG. Yeah. So who is going to give me definition of recurrent pregnancy loss? I'm sure you guys must have read your Green Top guideline and this TOG article as well. So anyone, any volunteer? What do you guys know about this, the recurrent miscarriages or RPL or recurrent pregnancy loss, whatever? Anyone? Okay, no problem. So this is the recurrent pregnancy loss definition used in different guidance. Yeah. So what we need to do is, because we are working in terms of, the MRCOG, so we have to do MRCOG guidelines and it's, the recommendation. However, because recurrent pregnancy loss has got multiple guidelines. So we have got Royal College of Obstetrics and Gynecologists. Initially, when this talk was, published in 2022. So at that time, we never had that, the new guideline in 2023, June 2023, which has been revised recently. So then we do have, the ASRM 2012 guideline. Then we do have European guideline of 2017. So how do they define recurrent pregnancy loss? In RCOG, they say all pregnancy losses not further defined. Okay. It means all pregnancy losses up to 24 weeks, and they have to be 3. Either, earlier it was consecutive, but in new guideline, they have changed it up to, they said that it could be consecutive, it could be, the non-consecutive as well, because the etiology is same. All right. So in the new guideline, they are concluding this. Okay. So this is going to be a new change in 2023 guideline. However, ASRM guideline says the clinical pregnancy defined by scan, ultrasound, or histological examination. And it only mentions that majority is lost prior to 10 weeks. So this is, a very, very earlier gestation, isn't it? 10 weeks. And they are only 2 and they are consecutive. Tertiary guideline says that whenever a woman is having serum or urinary beta-HCG positive, plus ectopic and molar pregnancy, which is not included in this definition. And they say that it is up to 24 weeks and 2 consecutive or non-consecutive losses. Again, 2 losses here, and RCOG says 3 losses. It could be, the consecutive, and it could be non-consecutive as well. So considering the differences in definition, it is difficult to accurately calculate the prevalence of recurrent pregnancy loss. While 1 in 8 recognized pregnancies end in pregnancy loss, the prevalence of RPL is about 1 to 3%. Exam question right away. So this is going to be a very important, the slide in terms of, first of all, you need to know that how you are going to define. Secondly, you are going to just check that, what is the prevalence of RPL in the pregnant population? So this is going to be 1 to 3%. So RCOG guideline 2023 change says that recurrent miscarriages has been defined 3 or more. See, 3 or more first trimester miscarriages in keeping the previous RCOG guideline of 2012. However, clinicians are encouraged to use their clinical discretion to recommend extensive evaluation after 2 first trimester miscarriages. It means when consecutive or non-consecutive first 2 trimester miscarriages are happening, so you need to get alert. You need to investigate, and with the further suspicion that the miscarriages are of pathological and not of sporadic nature. For example, if a woman has had a pregnancy loss with a normal, non-invasive prenatal testing or karyotyping. I'm sure you guys know that we have got two types of miscarriages, isn't it? Sporadic and second one?
Recurrent. Recurrent.
No, sporadic and yes, come on, guys. How many types of miscarriages do we have, in terms of if we talk about simple miscarriage? Okay, one is going to be sporadic miscarriage and the second one? Come on, guys. You guys didn't study this one? Nobody has read this guideline. Come on, Anam, Arjumand. Abdul Rahman, Nada, Nighat, Sana. This is this is amazing. Sporadic and the second one is consecutive, no, spontaneous, pathological. Sporadic and recurrent. Okay, sporadic means which is occurring in the first trimester, and that can be because of any fetal chromosomal abnormality, right? And if we talk about recurrent miscarriages, so today we are talking about recurrent miscarriages. Okay, so if we talk about pathological is going to be the any miscarriage which has got any pathology. Okay, so this is going to be as a whole we can simply say that miscarriages could be sporadic or it could be the recurrent. All right, so when we talk about the sporadic nature means because of the any the kind of procedure, any kind of pathology. For example, in this they have given us a the example that a pregnancy loss after a non-invasive prenatal testing or karyotyping. So this is going to be a single the example of miscarriage. Then guideline says that owing to the fact that incidence of certain diagnosis doesn't appear to differ between women with consecutive versus non-consecutive. So that's why definition in the present guideline has not been restricted to women suffering with consecutive miscarriages only. So it means we can, the kind of change our, the definition. However, this is 3 or more now. Okay, 3 or more first trimester miscarriages. We can say that more than or equal to 3 miscarriages, consecutive or non-consecutive. Now this definition will complete. Okay, prevalence is going to be 1 to 3%. Then etiology, which is very much important. So when we talk about that, why recurrent miscarriages are happening, so we need to know that what is going to be the the etiology. So I did try to summarize a couple of the etiological factors, and then we are going to see what exactly we are going to see in all these etiology. So when we talk about number 1, chromosomal abnormality of the fetus, and the second one is going to be, one is chromosomal abnormality of fetus, second is going to be parental, right? Parental chromosomal aberration. Okay. Then any other etiology which comes in your mind? Nighat? Rita? Come on, guys. This is such an easy guideline. Structural, okay. Structural where? Anatomical. Yes, that is a very good, the name. APS, yes. So how do we say this is going to be thrombophilia, isn't it? Yeah, thrombophilia. So if we talk about thrombophilia, that is going to be, the hereditary, or that is going to be iatrogenic thrombophilia. Okay. So then, yes, things are going to be complete. So if we talk about the first etiological factor, which is chromosomal abnormality of the fetus, very important. So these are the commonest causes of pregnancy loss, and they are account for 70% of early pregnancy loss. However, 20% can occur between 30 to 20 weeks of gestation. Then numerical chromosomal abnormalities are commonest and include first trisomy, then polyploidy, and then monosomies. Right? trisomies. Which trisomy? Down syndrome, Tau syndrome. We have got, the adverse syndrome. Okay. If we talk about monosomy, the most common, the monosomy is going to be Turner syndrome. Later on, there can be other, the chromosomal aberration as well. So a trisomy is believed to occur as a result of non-disjunction during maternal meiosis 1. I'm sure you guys know from your basic genetics, meiosis 1, reduction division. Then the risk of chromosomal abnormality of the fetus is higher in women older than 35 years of age, which supports the association of aneuploidy and increasing maternal age. And this is a very important slide. This was my exam question. 42 years of age, what is going to be the risk of miscarriage? So this is 50%. Okay, so 12 to 19 years of age is going to be 13%, 20 to 24 is going to be 11, 25 to 29 is going to be 12, 30 to 34% years is going to be 15%. So you can see this is the, the lowest risk factor. But coming, from 35 years of age, it will increase. 35 to 39 is 25%. 40 to 44% years is going to be 51%. However, more than 45 years is going to be 93%, which is quite high. So memorize this, the very properly, because this is one of the exam question can be out of the age-related miscarriages risk. Then the other epidemiological risk factors and their potential effect on pregnancy loss. We always talk about alcohol, caffeine, exercise, family history of pregnancy losses, maternal age, of course, which is important. So alcohol, there is no evidence as direct cause of RPL, but it is sensible to avoid excessive intake. According to NICE guideline of antenatal care, no amount of alcohol or smoking is allowed in pregnancy, right? So if somebody is planning to get pregnant, so of course it is sensible to avoid excessive intake. Caffeine, sensible to avoid excessive intake. No evidence as direct cause of RPL. Exercise, high intensity occupational activity, it is going to pose a risk. So it is sensible exercise levels is encouraged. Not the vigorous one, but the normal, the day-to-day exercises. So family history, women who miscarry are more likely to have a family history of pregnancy losses. However, further research is still needed. So we cannot say that, okay, my sister is having recurrent pregnancy loss, so I'll be having the same. No, we still need to collect the data. We still need to do the further research to embark on this, the particular line. So it can be plus, it can be minus. Maternal age, yeah, it is important. Aneuploidy pregnancy loss numbers specifically increase. Environmental exposure, no evidence as direct cause of RPL, but it is sensible to avoid exposure to possible hazardous substances during pregnancy. Paternal age, very important. Maternal age, and then comes paternal age, age of the father. So risk will increase with the advanced paternal age significantly after 40 years of age, but it is less pronounced. Can anybody tell me there is one condition which is associated with advanced paternal age? Anybody has any idea? One congenital, the abnormality which can be associated with advanced paternal age. Okay, it is achondroplasia. Okay, so sometimes it is said in genetics books that achondroplasia can be associated with advanced paternal age. So then comes previous pregnancy loss. Increase with the number of previous pregnancy losses. So percentage of pregnancy loss with euploidy increase. You mean when there is going to be a normal chromosomal structure. So, the recurrent pregnancy loss can be, associated with this. Smoking, no evidence as direct cause of RPL, but it is associated with poor obstetric outcome if either partner smokes. Because I'm sure you guys know that smoking, if it is active or passive, both are hazardous. Stress, directly no evidence as direct cause of RPL, but, itself, RPL can cause significant stress. It can be emotional, psychological, physical, yeah. So that's why when we will talk about management, so the stress relief or management or, the counseling is going to be our mainstay in terms of management of RPL. What about weight and BMI? Risk will increase as BMI will increase above 25. So evidence from associated reproductive treatment. So it says that's why, we need to have the balanced BMI when we will talk about management. So it has to be between 19 to 25, ideal BMI. Then second, first we have said fetal chromosomal abnormality, then parental chromosomal abnormality. So parental chromosomal abnormalities are going to be 2 to 6%. Most commonly, balanced reciprocal or Robertsonian translocation. So it will have a high chance of a healthy live birth in future pregnancy. So it is, if at all it has happened, so there are high chances that they can have a live birth in the future pregnancy. Then third cause is going to be congenital uterine anomalies. Now we are, labeling them as CUAs. It is associated with RPL. Prevalence is 13.3. With a history of miscarriage completed compared with 5.5% in an unselected population. In high-risk population, septate uterus is commonest one. So this is exam question. Septate uterus, okay? The same, our RCOG guideline is talking about, the septate uterus again. Most people with CUA experience a normal reproductive outcome later. Fourth, acquired uterine anomalies. So any acquired uterine malformation such as fibroid, polyp, adhesions, they have been found with RPL, but there is lack of evidence as a direct association. What about chronic endometritis, CE? It can be associated with RPL in several studies. However, the actual prevalence is hard to describe. So that's why whenever we think that somebody is having endometritis, so we will give them, the antibiotics, we will be treating them in the lines of pelvic inflammatory disease, right? Because there can be ascending, the inflammatory infections through vagina, right? It can cause cervicitis, it can cause endometritis later on. Chronic endometritis later on can lead to, the fallopian tube abnormalities and all. So, indirectly, it can be associated with RPL. So what about cervical insufficiency? It is more common in second trimester. I'm sure you all know. But there is no recommended investigation for cervical insufficiency outside the pregnancy. So there is no role that if somebody is going for, cervical length outside the pregnancy, it is not going to be benefited either way. Okay, so once woman is going to be pregnant and once woman is going to give us a history of second trimester loss or preterm labor, so in that scenario, we are going to go for, cervical length assessment, transvaginal scan. So no further discussion. Hydrosalpinx makes sense. So they have done a systemic review and meta-analysis in 2019. So they said that it can increase the risk of pregnancy loss itself and the treatment can reduce the risk. And we all know that, when we are talking about, the hydrosalpinx or pyosalpinx, so we are talking about IVF. So if anybody is having, the hydrosalpinx or pyosalpinx, we will go for first salpingectomy and then we will go for IVF procedure. Why? Because the toxic fluid which is accumulated in this tube. So when IVF will happen, when implantation, they are going to do the embryo transfer. So at that time, this toxic fluid can flush off, the embryo. That's why it is said to be, okay, go for salpingectomy first and then go for IVF. Because for IVF, we just need tubes and we just need uterus and ovaries. Then hereditary thrombophilia. We have said earlier that thrombophilia is a cause. So thrombophilia can be of two types, hereditary and acquired. So when we talk about hereditary, it can be factor V laden gene mutation, prothrombin gene mutation, deficiencies in antithrombin protein C and protein S. So evidence is weak for association with RPL. But APLA, acquired thrombophilia, it's the commonest acquired thrombophilia with a prevalence of 5 to 20% in RPL patients compared with 2% in those with a low risk obstetric history. So it has been described as the most important treatable cause of RPL. So maybe they can, give you a question that which of the following is the most important treatable cause of recurrent pregnancy loss. Okay, so the answer is going to be antiphospholipid antibody syndrome. Then the thyroid disorders, diabetes mellitus, any endocrinological disorders. So basically, they don't have any direct association with RPL, but yes, thyroid or, if somebody is having diabetes, so they have to be maintained. So they say that there is no association with subclinical hypothyroidism and RPL. But there can be an association with RPL and thyroid autoimmunity, Graves' disease, right? So in that scenario, the patient needs to be treated. However, it is not going to alter their outcome later on, because, RPL can be because of, any reason, because most of the time it is chromosomal abnormality, right? But this way or that way, a woman should be in the good shape once she embark on pregnancy. Same goes for diabetes. So a high hemoglobin A1C in the first trimester will increase the risk of pregnancy loss and fetal malformation as well. On the other hand, well-controlled diabetes is not a risk factor for RPL. What about prolactin disorders? No clear evidence that either prolactin deficiency or hyperprolactinemia can cause RPL, but there is evidence that bromocriptine treatment for hyperprolactinemia will increase live birth rate. I think I have seen one question here and there about bromocriptine. See, the difference is this, that if at all a woman is having hyperprolactinemia, and if we give them treatment in terms of, the bromocriptine, so there can be chances that live birth rate can be high. Okay, because I'm sure you guys know that first there is going to be, the pregnancy. Okay, then pregnancy rate. Sometimes there can be live birth rate, because not every pregnancy will have a live birth outcome in terms of when we talk about certain disorders. So this can be, a good question. Then polycystic ovarian syndrome. So it has got some association. So it is potentially related to hyperinsulinemia and hyperandrogenemia. But PCOS itself has no link which can predispose to RPL. On the other hand, if somebody is having, the PCOS, because later what it will cause, hyperinsulinemia, hyperandrogenemia, it will cause, the hormonal imbalance. It will cause, the problem, morphological problems in the ovary. So ovaries might not be able to release proper egg. So in that scenario, yes, there can be chances of, the pregnancy loss as well. Then what about luteal insufficiency, luteal phase defect? Simply, we used to say earlier LPD, luteal phase defect. Now because we don't have any clear definition for luteal insufficiency, so we cannot say that it has got a direct link with RPL. So what about male factor? So now there is, the growing evidence that suggests association between RPL and poor quality sperm. However, this remains a controversial subject as well. But these days, multiple studies are going on, and they are trying to find out, increased sperm DNA fragmentation index, DFI, that it can be associated with RPL, but still, the studies are going on. This strong article was published in 2022. The same thing has been written in the Green Top guideline as well, that, male factor can be associated with RPL. However, we still need, the more data, more researches to just, conclude this, that, okay, male factor could be a sole cause of RPL. Then 17th cause, unexplained recurrent pregnancy loss. So some of the RPL patients will never identify a reason for their pregnancy losses. So later on, what we do is we do adjuvant treatments. Sometimes, sometimes they can have mixed outcome. A retrospective cohort review, which was published in 2018, so they said that, okay, we can give adjuvant treatment. Like, in terms of pregnancy vitamins, folic acid, and, the anything which can, improve against placebo. So more than 2/3 of those with RPL will have a live birth in a subsequent pregnancy, and empirical adjuvant treatment for these patients doesn't appear to offer any additional benefit. But it can have, the role. Again, it is not clear. Okay, clear so far, guys? Now, because we have figured it out that, okay, these could be the potential factors for RPL. And when we will talk about management, we will take, all these factors and we will try to manage them. Clear, everyone? Clear so far? Clear, everyone? Okay, very good. At least say yes or no. So we'll be good to go. All right, good. All right, great. Okay, now when we talk about management, okay, now I'm sure you must have been seeing, the patients with RPL or even, the sporadic miscarriages in your clinic, in your hospital as well. So what we expect if somebody has lost her child, her baby, and for example, if it is recurrent miscarriage, so we will be seeing a couple who are distressed, who are upset, so what we do, we talk to them, right? We give them, the proper, the counseling. We give them support, emotional support. We talk to them. We do try to listen to them, because the feeling they can describe for the pregnancy loss, it could be sadness. Patient can be depressed. Patient can have some kind of guilt, because many patients who come to us and they say, perhaps it was, some kind of default in me or my partner that, we have got this loss. But what we need to, do, we need to support them, right? We need to support them. So this supportive treatment is going to be the mainstay in the treatment of RPL. And trust me, if we bring this, the supportive treatment in our practice, half of the problems of patients will be resolved. So the management is going to be according to, the cause, first of all, and the general treatment as well. Lifestyle modification, psychological support, and specific treatment. So ideally, they have to be seen in the RPL clinic, and there should not be only women who should be seeing you. Always encourage couple, okay? Because, the partner is equally responsible, okay? Or maybe he is equally devastated because of this loss, and that happens. So if you call them, the in together, if you talk to them, this is going to give a very positive impact on their, the well-being altogether. So it is very much important. Then if we talk about, because we just have spoken about, the causes, right? So then we have to evaluate. First of all, general, we have to do some investigations. If we feel that somebody is having any genetic problem, so we will send cytogenetic analysis on product of conception on 3 and subsequent pregnancy losses. However, this is 2011 guideline RCOG. 2023 says after 2 miscarriages, you will be alert and you will be seeking, the help in terms of that what is causing all these miscarriages. So if at all we see that if unbalanced structural chromosomal abnormality is there, we will go for parental karyotyping. If we see that if somebody is having, hereditary thrombophilia, hereditary is going to be in the 2nd trimester loss. If it is APS, antiphospholipid antibody syndrome, and if we expect that patient can have this, we will go for lipase anticoagulant, we will go for anticardiolipin antibody testing, and we will do 2 tests, and those are going to be 12 weeks apart, 3 monthly. And, the value should be high enough, more than 40 at least, to, the label somebody with APS. If at all somebody is having endocrine abnormality, RCOG even now doesn't support that. We just need to go for, the thyroid or, the diabetes until and unless history is suggestive of. Uterine anomaly, we will go for transvaginal scan, and that can be assessed further with hysteroscopy or 3D ultrasound if abnormal. Male factor, yes, there can be, the DFI, okay, DNA fragmentation index. Immunological, no, not yet. ASRM, however, and ESHRI, they are going to be talking about all these things. They are going to do 3D scan first. They are going to do, the lipase anticardiolipin antibody, anti-beta-2 glycoprotein antibody as well. So, yeah, but we are concerned with RCOG. So, when we talk about treatment options, apart from, the general measures, we will go for treatment option as well. If there is any balanced chromosomal abnormality, first we will send for genetic counseling. We may go for IVF and PGD, right? APS, if there is APS, we will give them low-dose aspirin and heparin. If there is any hereditary thrombophilia, however, there is insufficient evidence that, we are going to treat or diagnose for the first time in pregnancy, because hereditary thrombophilia are best diagnosed outside pregnancy. Because this way or that way, patient is going to be a known case. If at all we expect that somebody is having thyroid problem, hyperthyroidism, diabetes, or hyperprolactinemia. So first of all, we are not going to evaluate First, we will take a detailed history examination, and if history and examination is suggestive of any abnormality, only in that scenario we will offer them, thyroid or diabetes testing. What about uterine anatomy abnormality? So there is insufficient evidence, but we will talk about it because there is evidence now. Unexplained, if at all unexplained abnormality is there, we will give them supportive care in a dedicated early pregnancy assessment unit. Supportive care is the mainstay for the treatment of any miscarriage there is, be it recurrent, be it sporadic. Okay, because we have just said that more than 2/3 can have a live birth afterwards, 70% can have live birth after having supportive care. So it is very much important. Then, if we have to go for any chromosomal abnormality, we will go for PGT, anatomical factor. If there are any, iatrogenic, if there is fibroid, we will do, the myomectomy. If there is polyp, we will do polypectomy. If there are adhesions, we can go for hysteroscopic adenolysis as well. But yes, treatment is going to be according to the cause. Thrombophilia, if at all. So yeah, for thrombophilia, we have to give unfractionated heparin, low molecular weight heparin, and low dose aspirin for APS. If at all there is an evidence of endometritis or infection, we will give antibiotics accordingly. Immunological, so far no role, natural killer cells and all, so no role as such. Endocrinological, if at all, she turned out to be the known, the case of diabetes, hypothyroidism, hyperprolactinemia. So yeah. So we have just concluded that bromocriptine can bring about increased chances of live birth rate. This is important, the concept, and it could be a question as well. If at all there is a male factor, so we can go for lifestyle modification. We can give them, the antioxidant in lines of, male factor infertility TOG article. Unexplained infertility, if at all there is. Yes, there is, sometime, the role of unexplained, the recurrent pregnancy loss, there can be role of progesterone as well. But yeah, still we do need a couple of studies. Generally, maintain normal BMI, stop smoking, give them vitamin D, they check their total leukocyte count, and, they see them in the recurrent pregnancy loss clinic. Okay, so they have to have, the proper counseling. So the guideline, the management from the guideline says almost the same, but, the few things are very catchy in this. So I thought it's better that we cover this, the whole guideline in one sitting. So first of all, it says the same, that ideally the couple should be seen together in the dedicated recurrent miscarriage clinic. Okay, and they should be given accurate information to facilitate decision-making about future pregnancies. They have to maintain their BMI between 19 to 25. Smoking cessation, limit alcohol, and limit caffeine, at least less than 200 milligrams per day. Give them aspirin and heparin, if they turn out to be having, the APS. Okay, so when you are going to start, very important, 75 milligram aspirin orally and 40 milligrams subcutaneously enoxaparin from a positive pregnancy test until at least 34 weeks. They say until at least. It doesn't mean we are going to stop at 34 weeks. Okay, don't stop, because aspirin can be given till the time of birth as well. Okay, if you go for this low molecular weight heparin, enoxaparin, so yeah, that can also be given, provided you are doing proper bridging at the time of, delivery or induction or whatever. So clinicians and women should be aware that treatment with heparin, particularly UFH, is not without some risk. So UFH can cause thrombocytopenia, HIT, it can cause, some kind of allergic reaction. It can cause later on, these problem, bruises and blah, blah, blah. So aspirin and or heparin should not be given to women with unexplained recurrent miscarriage. Exam question, straight away. So what is going to be the mainstay for unexplained recurrent miscarriage? Supportive treatment in dedicated RPL clinics or in early pregnancy assessment unit. So routine treatment for women with factor V laden, protein C, protein S deficiency, to reduce the incidence of recurrent miscarriage or second trimester loss. There is lack of evidence because we have just said that congenital thrombophilia should be diagnosed and should be started on treatment before pregnancy, not very first time in pregnancy, because certain factors can be changed because physiological and hematological changes in the pregnancy. So a decision to treat women with recurrent miscarriage for second trimester loss can be individualized again. And if we feel that the reason is thrombophilia, so we will be taking RCOG Green Top 37A, VTE, okay? Or if there is the taking into account, and then we will talk about all those, the management options. So treatment can be considered given the association of thrombophilia with thrombotic events. So option for couples with chromosomal rearrangements could be attempting a further natural conception, number one, PGT, gamete donation. Live birth rates are similar following natural conception and PGD. So PGD should not be routinely offered in this situation. However, we can pick certain chromosomal abnormality through, PGD. So there are currently insufficient data to support the routine use of PGTA for couples with unexplained recurrent miscarriages, while the treatment may carry a significant cost and potential risk as well. Of course. So we do need, a lot of data. I'm sure you guys know that if we talk about IVF and if we talk about PGD, so yeah, they perhaps, they are not going to be NHS funded, and, the one cycle of IVF can cost them for about, the £7,000, £8,000 to £10,000. So it all depends on, if they are well supported by their trust, if the trust is giving them, the enough support cycles, the IVF cycle and all. And what I know is PGD is not most of the time funded, but IVF can be. So what about, we have just said that septate uterus is an important cause of RPL. So resection of uterine septum should be considered for women with recurrent first or second trimester miscarriage, ideally within an appropriate audit or research work. Okay. PGT is same. Okay. PGD, pre-implanting genetic diagnosis, and PGT is treatment. It's same. There is a lack of evidence to guide the management of acquired uterine anomalies associated with recurrent miscarriages. So counseling and the choice of expectant versus surgical options ought to be individualized again. If somebody is having fibroid, if somebody is having any polyp, so if at all it is not causing any harm, any problem, but yes, it is causing RPL. So in that scenario, we will talk to the woman. We will tell them all options. We will tell them that, okay, it can improve, the pregnancy chances, but it may not improve the pregnancy outcome. Because not every pregnancy will be having the live birth or the good pregnancy outcome. So if there is any suspected cervical insufficiency, so we will go for preterm birth guideline. Like I said earlier, that we will go for transvaginal scan, and we will look for, the vaginal length, cervical length, and then we will go for treatment options accordingly. So thyroxine supplementation is not routinely recommended for euthyroid patients with thyroid peroxidase antibodies who have a history of miscarriage. However, if they are found out to be having, the antibodies, or if they are known or new diagnosed case of hypothyroidism, then yes, we can offer them thyroxine, and later on it can improve, the birth outcome as well. So it can be considered with moderate subclinical hypothyroidism. But again, it is not routinely recommended. Regular TSH measurement from 7 to 9 weeks is recommended in cases of thyroid peroxidase antibody and or subclinical hypothyroidism. This is a very interesting and new thing in the guideline. So we can go for it. Progestogen supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy. It can be 400 milligram micronized vaginal progesterone twice daily at the time of bleeding until 16 weeks of gestation. See, this is also very beautiful clinical tip for all of us clinicians as well, isn't it? So we can give them. If they are coming with bleeding in the early pregnancy, so in that scenario, we can give them 400 milligram micronized vaginal progesterone. Okay, twice daily at the time of bleeding until 16 weeks, because after 16 weeks, placenta will, they start functioning properly. It will produce enough progesterone that we don't have to stuff a woman with progesterone from outside. But routine progesterone supplementation should be used with caution in asymptomatic women with unexplained recurrent miscarriage. Another important thing. Because if we have labeled somebody with unexplained recurrent miscarriage, we cannot give them, any progesterone. Sadly, unfortunately, in many hospitals, in many clinics, and many parts of the world, there is a very malpractice of giving, the injections, injectables, progesterone, these pessaries, these tablets, and what is it causing? What is the effect and the side effect of progesterone? Anyone? It can cause headache, bloating, breast tenderness, weight gain, mood disturbances, nausea, vomiting, right? Water retention. Later on, how patient presents undiagnosed hypertension because of no reason. Because somebody is stuffing them with progesterone in so many forms, tablets, injections, pessaries. So this way or that way, they are functioning in body, isn't it? So women may present with, the hypertension. So I personally, being an obstetrician, I do try to, limit all these hormones in pregnancy, outside pregnancy, and everywhere. So be extremely careful, If you are giving, the one form of progesterone supplementation, that is okay. But don't give injections, pessaries, and, the oral tabs as well. One is okay. All right. Then what about, the immunotherapy and male factor treatment, endometrial scratch? So usually they are not recommended as such. Okay. So they are not recommended as such. When we can give, I don't give. Injectables, progesterone are recommended for IVF treatment. And later on in IVF, where we need to give proper support, only in that scenario we give. Otherwise, injectables are not given. But sadly, many clinicians, they do it. And I think which is very, the alarming as well as wrong and malpractice as well. Okay. All right. So immunotherapy has no role, no evidence to recommend treatments for male factor. Endometrial scratch is not recommended for unexplained recurrent miscarriages. Again, if we talk about IVF, so in some IVF setting, they go for this endometrial scratch, they just do the, the fine curating and just do this scratching before doing the embryo transfer. In some settings, it can be good. In some settings, it cannot be, the helpful. So it all depends on. So we will not offer any routine endometrial scratch. Then unexplained recurrent miscarriages should be offered supportive care, ideally in the setting of dedicated recurrent miscarriages clinic. So very important that almost more than or equal to 2/3 of women will have good pregnancy outcome later on, live birth rate. Okay. So I think this was all about this TOG article and guideline. I did try to summarize both things. So I hope things are easy now. Clear, everyone? Any question? Clear, everyone? Thank you, Arjuman. Thank you so much. Thank you so much. Thank you, Anam. Thank you. So this way, we have concluded our, the complete topic, isn't it? So we have completed our whole topic of recurrent miscarriages. We have done TOG article and we did try to summarize our green top guideline as well, isn't it? So if you can see that couple of good things are here, okay? So you as an exam candidate should know that what are the new recommendations in the new guidelines. So few things are changed from old guideline. Yeah. So we are doing, this few things in the recurrent miscarriages. You saved me. Okay. All right. All right. That's good. That's good. So any question, guys? Any question? So always remember when you study anything, especially the TOG article. Okay. So, you have to, you have to do properly. Okay. So when you do talk article or any guideline, do try to think that, first of all, what is going to be the etiology, what is, the prevalence, what are going to be the risk factors. Read any talk article as a story. If you will read a talk article as a story, trust me, things are going to be very easy. Okay?
So, Zaib, I have one question, please.
Mm-hmm.
In case of subclinical hypothyroidism, if there is antibody, such condition, shall we give thyroxine or not? Just follow up thyroid.
No, subclinical hypothyroidism, for example, if it is, with any thyroid peroxidase antibody, so we don't give. Even clinically, we don't give until and unless, it is a very pronounced, the peroxidase antibodies are positive and patient is showing signs and symptoms of hypo as well. So yeah, in that scenario, we will give, but not in subclinical. Okay.
You mean, doctor, when it's combined, you mean subclinical plus antiperoxidase?
No. You didn't get this thing. Anti-peroxidase antibodies are present where? In Graves' disease. Okay, Graves' disease is the cause of hypothyroidism. So if somebody is having hypothyroidism, if somebody is having TPO antibodies, but her TSH is more than 2.5, okay, so we will not give them, the thyroxine supplementation. But yes, if they have moderate subclinical hypothyroidism, TSH is more than 4. Okay, so in that scenario, it can be considered. So it all depends on, the level. It all depends on, how patient is presenting and all. Okay. Definition after 3 losses, it is 3 or more. Okay, 3 or more losses. We will start working. We will start trying to find out the cause of recurrent miscarriage after 2 losses. Okay. And it can be consecutive or it can be non-consecutive as well. Okay, Shandar? So this is, the definition now complete. All right, 3 or more less than 24 weeks or up to 24 weeks, consecutive or non-consecutive. All right, so this is the new definition. So a couple of things are, the very beautiful in new guideline. So do try to read guideline. Very important, very, very beautiful, I must say. A very beautiful guideline, in fact. Okay. So do try to concentrate on all, the charts, tables, and do read them. Study, and, the discuss. Try making a habit of discussing with your fellow colleagues, with your peers, and ask from your, the mentors and all. Okay. So, this is going to be somewhat where you have to do. Okay. All right. Okay. All right. Any question regarding RPL, guys?
Dear Ma, I'm asking about follow-up if the patient is have thyroid antibody.
Sweetheart, we are not discussing thyroid disorder. That is a separate, a complete package. So if you are really intrigued, you can go through TOG article on thyroid disorders. I'm sure, you are going to be benefited. Okay. Because if you have to study clinically, so trust me, that thyroid disorder, I think that's the 2013 TOG article on thyroid disorders. That is very helpful. Okay. Okay. Very good. Okay, that's good. That's good. Brilliant. Sadaf, any questions? Saleha? Murax. Are you the same Murax? How are you? Maimuna, Arjuman, Nighat, Nada? Is everything clear? Hi. How are you doing, Murax? Okay. So good to see you. I hope you're doing well. Yeah. Okay. That's great. All right, guys. So I will try to. I know you have cleared your exam, and congratulations. I'm so happy. Very good. So are you still in Australia or you have moved to UK? Oh, yeah, Canada. Okay, fine. Okay. Okay, that's great. Yes, he's our, the very dear student from MRCOG Part 2 and Part 3, Muraks. And he is at the moment in Canada, and he was a brilliant candidate, and I'm so happy to see him. All of a sudden, I just saw the name. I said, okay, Muraks, is this Muraks? Okay. That's great. All right. Okay, guys. Okay. Thank you so much for being, the very brilliant audience. Thank you so much, Muraks. This really gave me a pleasure, because all of a sudden I just saw your name and literally, I felt so happy, very happy to see you. Okay, very good. Okay, guys, I will catch you inshallah in some other session so soon, perhaps, after 15 days. So we will discuss another talk article. So do try to, join our, the Telegram groups, Facebook groups. So we might be having, these certain announcements, in near future that is going to be beneficial for all of you. Okay. So study hard, study smart, and stay focused. Bye-bye. Allah Hafiz.